South America. I was in Peru. I went home to visit family, and all right, D's here now. All right, without further ado, I guess we'll go ahead and get started. If there's anybody else that trickles in, we'll just kind of receive them. But
I'm gonna go get my.
yeah, no problem.
I'll just show you guys.
Well, Dr. Worth, I'd like to thank you and tell you good afternoon. Really appreciate you dedicating, some of your busy time. I know we all have really busy schedules, but we do feel that this is very important to take care of these, talk about these problems, because that's the only way we're going to get better at managing these patients. And that's not something we typically do all the time, but we do deal with a lot of chest tubes. So I felt that it was important to talk about these issues. So the article that we selected was the management of pneumothorax and prolonged air leaks. It's a study from the United Kingdom, but I figured, I don't think it's going to be any different than what we deal with. Anyways, so the first thing that I read, pneumothorax, everybody knows what pneumothorax means. It was first used in 1803 and adopted by René Laennec, who adopted it in 1819. It talks about, the difference between primary spontaneous pneumothorax, which is usually seen in healthy people, and then the secondary spontaneous pneumothorax is usually associated with an underlying lung disease, such as, any lung disease really, COPD, Ehlers-Danlos syndrome, Marfan syndrome. Smokers apparently was a big thing. They have an increased risk. And the most common cause I was not aware of is historically has been tuberculosis.
Yeah, historically, yeah. And across the world, yeah.
So another thing that we saw is the incidence of primary spontaneous pneumothorax is about 18 to 28 per 100,000 for men, and 1.2 to 6 per 100,000 per year in women. So women have a lower incidence rate of spontaneous pneumothorax, but men usually have a higher rate. I was wondering if you can correlate that to your practice. You usually see men having, spontaneous pneumothoraces higher than women, or is it a mix, or it's about the same?
Yeah, I think that's a great question, but I do feel like in my experience it tends to be more women than men. And certainly, historically the spontaneous pneumothorax of the 18 to 22-year-old male, not female. Where I've seen it more often in younger female patients will be catamenial, so when it's related to endometriosis. You can get these, we all can have these pores in our diaphragm, so the endometriosis implants can traverse the diaphragm and end up implanting in the chest, and then those patients can get recurrent spontaneous pneumothoraces related to their menstrual cycle. But, yep.
And what do you normally see? Does the data correlate to your practice as well? Do you see primary spontaneous or secondary spontaneous pneumothoraces?
Oh, definitely both. The primary ones are going to be your younger patients, and maybe not. I don't know if you could argue the catamenial ones are their primary or secondary, but so you get a handful of those, and then probably the majority are going to be your older patients with COPD or had some sort of cancer intervention or that kind of thing.
Gotcha. So, welcome guys. So for primary, I was also noticing that although there's no underlying lung disease, usually when we do a CT scan, which is pretty much standard nowadays for when someone comes in with a pneumothorax, is you find some subpleural blebs and bullae, which is commonly seen in thoracoscopy, but we're not doing that routinely. We're doing more CT scans. Because you can get a chest X-ray, which is usually sufficient, but when they're small pneumothoraces, in my experience, I have a hard time finding them when they're small. Sometimes initially you don't see it, and then when we redo the CAT scan, especially with like rib fractures or traumatic injuries, that's when with the CAT scan when we definitely see it. I was wondering if that's also something that you experience. You find it to be more
definitely with CAT scans, we pick up on more things than you would have with a chest X-ray. I think that though kind of just speaks to sometimes with the patients the relevance. If it's not big enough to be picked up on a chest X-ray, and that's the main way you're going to follow it. Sometimes they're less relevant if they just show up on the CAT scan. That might be one that you just keep an eye on versus consider placing a tube.
Got it. Like as we mentioned earlier, smoking is strongly associated with pneumothorax spontaneously. Smokers have a 12% chance of developing a pneumothorax as opposed to non-smokers who have a less than 1%. It's actually very low, 0.1 chance of pneumothorax. I was wondering if you also correlate that to your practice.
I feel like, certainly pretty much all the COPDers are smokers.
Yeah.
Yeah, hard to say. I don't know, it's hard. I feel like all my patients are smokers really, but.
And these spontaneous pneumothoraces are usually well tolerated apparently by young people. They usually don't have significant symptoms, but some of the symptoms that they experience are chest pain, breathlessness, or difficulty with breathing. And these, they can be either very minor, delayed, or absent. My question would be, if they're slightly symptomatic or asymptomatic, and they have, I think I asked you that the other day, because I was working at LMM, and a young guy with primary spontaneous pneumothorax came in. I calculated it to be about 20 to 25%. To me, it was significant, but it was treated non-operatively or conservatively. I was under the impression that if you have something greater than 10%, that it required a chest tube because of the risk of trapped lung. However, when I read the article, I was surprised that they actually recommend doing conservative management. You can kind of get away with not putting a chest tube in. So I was wondering what your recommendation would be in your experience.
Yeah, I think it just kind of depends on the patient and the scenario, to be honest. So if it's, like you said, a young healthy person, their vital signs are stable, they're not hypoxic, they're not complaining of chest pain, they're not tachypnic, they're not tachycardic, if they're coming into the ER and it's a pneumothorax that's limited to the apex, that's fairly small, you can get a follow-up X-ray 4 hours later is how I usually do it. If that's stable, then if they're a reliable patient, then we can see them back in the office in the next couple of days with a chest X-ray and just kind of monitor it that way. For me personally, in my experience, for those patients, I'm looking at the top of the apex and seeing, like, sometimes it's really just all up in the apex, but you can see it kind of dip down and it'll start pulling away laterally. And once I see it start pulling away laterally, that's when I think, it's probably bigger than that CT phenomenon, where if you get scanned, you might think it was bigger than what you're seeing on the chest X-ray, and then those probably deserve a chest tube. But it's really okay to take it on a patient by patient basis and kind of see what the risk benefit ratio is for each patient.
Okay. So would you say that we shouldn't really have to focus on the percentage of the pneumothorax to base our decision whether we should place a chest tube or not?
No.
Okay. But that's one thing, like I said, that's the way kind of we are trained here. So, after this talk, I guess this will change our practice. So it's good that we're talking about it. Because like I said, in the beginning, when I first started doing this, I was trained that, anything greater than 10% will likely require a chest tube, but I'm quickly learning that that's not the case.
Yeah, no, not necessarily.
Got it.
I would just look at it on a case-by-case basis. And, you could also make the argument too, that patient that you're describing at LMM, I don't know why he came to the ER, but was he truly asymptomatic? He probably came
he had a little bit of discomfort, but he was not hypoxic. His saturation was 97, 98, on room air. He just had a little bit of discomfort, and that's kind of why they did a chest X-ray. And that's when we found I thought it was significant, 25%. And I suggested maybe, but then obviously I'm the PA, I'm not the one who makes the final decision. And the on-call surgeon said, no, we can just treat it conservatively, and that's kind of what the ED's plan was. Mm-hmm. So that's why, to my surprise, I was like, well, what about trapped lung? And apparently that's not the case. So it was good that he came in because I learned something, you know.
Yeah. Yeah, the bigger issue would be exactly what we're talking about here. You just want to make sure that they're not having an air leak. That's why I would get a chest X-ray 4 hours later in the ER. If they're stable, then we could send them home. Because the thing that you worry about missing is not trapped lung, but you don't want them to develop a tension down the road because they had an air leak that wasn't, appropriately addressed.
Got it. So I was also reading that in the modern era of medicine, now, with so many treatments of tuberculosis, it is no longer the most common cause of pneumothorax, but rather iatrogenic. So we are causing these issues nowadays. Some of the reasons why we cause these procedures or these conditions are from lung biopsies, from thoracentesis, circulating artery cannulation such as a triple lumen catheter or central line, and the ventilator, which we have seen pretty much all of these, except we don't really do subclavian lines here, but I have seen many pneumothoraces from biopsies, from incidental puncturing of the lung on a thoracentesis, and from vent. I've seen it. Even with COVID, I've seen, from coughing, I guess. So, I was wondering if you also correlate that to your practice.
Absolutely. Yep.
All right. So another thing that we needed to address was the persistent air leak, or in luncoplurofistula. So per the article, a persistent air leak is something that is continuous flow of air to the chest tube for greater than 48 hours. But I was discussing with Dr. J. Raman this morning, and he said that that's more for persistent, but not really for acute. And I don't think there was anything mentioning acute air leak in this article. So I was just wondering if you can kind of give us some guidance into what would be considered an acute air leak and what is a persistent air leak.
So the Society of Thoracic Surgeons, who runs our quality database for our post-operative patients, considers an air leak to be prolonged if it lasts for longer than 5 days after surgery. So 5 days is the standard that we use. I saw that 48 hours too, and I was surprised. I was like, oh wow,
That's short,
It sounds very short to me too. Yeah, I was thinking, oh well, I guess these are pulmonologists. Maybe they're more eager to intervene. But as a surgeon, I'm more comfortable just sitting and giving it some time. Where for most of these patients, these will eventually seal up on their own if you're patient enough. So they don't always necessarily require an intervention. But yeah, I thought the 48 hours seems a bit fast to me, but it could be that for a non-operative patient, that's more what the medical standard is, to consider it as prolonged or persistent.
Okay. So when would you say that you have an acute air leak? If I put a chest tube in and initially some of the air, some of the pneumo comes out, at what point do I say, this is an acute air leak? Because sometimes you get a chest, follow-up chest X-ray, you don't really see much air in there anymore, but you're still seeing bubbles.
Yeah. So whenever I'm checking for an air leak in the tube, I never check for the air leak on suction. So if I come into the room and the patient's hooked up to suction, the first thing I do when I walk in the room is kink the suction, and then I talk to the patient. And so we talk a little bit, how are you doing, blah, 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 all the casual stuff. And then I'll have them, the first maneuver I do to interrogate the atrium is I'll have them take a deep breath, and I want to see, do you see titling in the chamber? Because if there's no titling in the chamber, that tells you that the space is either sealed or you've got a problem and your circuit's occluded, distal to where you're somewhere along the line. And then if you see titling of the ball in the chamber, then the next step is I ask them to cough. Coughing for me is really hard to interpret if there's an air leak, because sometimes you see that ball, it just
up and down,
up and down so violently, and so it's really hard to tell. Is that just because they're just aggressively changing their intrathoracic pressures? And so Then the next thing I ask them to do is perform a Valsalva. So for most of the time, most patients, I tell them to try to blow their thumb up like it's a balloon, and I tell them, and I'll do it for them, and that's a good way to provoke a Valsalva. Or you can also tell them to bear down, like they're going to have a bowel movement, and hold it. And the idea is just to get them to Valsalva however you can. And that's a much more gentle way to increase your intrathoracic pressure to see if you can provoke an air leak. And if I don't see anything that I'm convinced is bubbling coming out, I should also add, especially in the post-operative patients, sometimes they can have an air space. So there's space in the chest because we've just removed a lobe and the chest hasn't accommodated to fill that space in. So for those patients, particularly when they Valsalva, or sometimes when they're coughing too, you're actually pushing out that air that's in the chest, and it's not an actual air leak. So that's another reason why I like the Valsalva, because you can see that they may have a bunch of air that rushes out, but then it stops as they hold the Valsalva, as opposed to as they're holding the Valsalva, if it just continues to trickle out, that's probably an air leak. And if they get some bubbles and then it stops, then that's probably just an air space. And then the next thing I do is I let the tubing go and reapply the suction while I'm watching the canister and see, do I get a whole bunch of bubbles that come out? Because that could be another sign that maybe there's just a small leak that for whatever reason wasn't coming out of the tube, and now I'm evacuating that space. So that's the way I interrogate a chest tube on every single one of my patients when I go around on them, and to decide whether or not they have an air leak. So I don't know if that answers your question.
Yes, thank you very much. Appreciate that. So as far as most common cause of a air leak is usually from secondary spontaneous pneumothorax, which is an underlying lung disease that is driving that air leak. Local pleural fistulas is usually a connection between the tracheobronchial tree and the pleural space, and most commonly seen with pleural resections, which makes sense, right? You're cutting through all that tissue, exposing some of the bronchial tree to the space. You can get that, but you can also develop it with primary or secondary spontaneous pneumothorax. Trauma, vent, lung infections, which makes sense, right? The tissue breaks down, and now you have a fistula, fistulous connection. So just wondering if you also see that in your practice.
We see that less frequently. I think you hit the nail on the head. The pulmonary abscesses, you have a higher chance of something like that developing, or really that's usually a postoperative complication related to the stable line on the bronchus, and particularly in a pneumothorax and in a pneumonectomy. In a pneumonectomy patient, that's a life-threatening event. You got to get that. If they present with a bronchopleural fistula, they present in extremis usually, and they're usually coughing up a copious amount of usually clear or yellowish frothy sputum. And after someone's had a pneumonectomy, the pneumonectomy space fills with fluid, and that's what, as that stump breaks down, that's what's coming out from the bronchopleural fistula. And so then when you shoot a chest x-ray, then you'll see in a space that had been full of fluid, you'll see an air fluid level, and that's a surgical emergency. You need to get a chest tube in that patient's stat, and then you need to get them on their side with the side of the fistula down to protect the other lung, to make sure it's not getting soiled from all that stuff that's coming in. But those are very, very rare.
Okay. Do you see them ever with any of your lobectomies or your partial resections?
Yeah, less so with a sublobar resection. It is certainly possible with a lobectomy, and I have seen it. There's one patient I can think of in my practice. She had radiation after her lobectomy, and so usually it's because there's been some sort of other assaults to the airway that would lead to breakdown.
Okay. What the article recommends, for treatment of these is, like you said, chest tube, and if it's an infection, obviously broad spectrum antibiotics, but also kind of like a enterocutaneous fistula from the general surgery side is optimating their nutrition status too, because that might, help heal the fistula a little bit sooner. Some of the treatments for the bronchopleural fistula I found quite interesting because my interventional radiology background, there's a lot of tools that we use in IR for peripheral vascular disease. You know, some of these things are tissue glue and sealants such as methyl 2 cyanocryolate. You know, we used to use that for AV malformations. Gel foam that we use for GI bleeds or any sort of, you know, traumatic hemorrhage. Fluorescents such as ethanol, which is commonly used in IR for AV fistula malformation treatment, right? In neuro IR as well. And then thermal energy, which is like a laser, I guess, cautery of some kind. And then most interesting thing was the occlusive devices such as I've never seen this one, the Watanabe spigot, and then a silicone plug, and then stents, vascular coils, which I'm very familiar with, and the Amplatzer device, which I'm also very familiar with. I was just wondering if you ever used any of these options for treatment of a bronchopleural fistula.
So I would say two things. So first of all, this article is based on interventional pulmonary.
Yeah.
And so what they're going through is everything that's in the toolkit of the interventional pulmonologist. We do have an interventional pulmonologist who is a part of the thoracic surgery division. He's one of my partners. He's not in the Department of Pulmonary Medicine. He's actually with thoracic surgery. And he does quite a few of these things. You know, a lot of times our first move is to do something like you guys did today, just do a simple good old-fashioned pleurodesis. That can be done either with a blood patch or a chemical pleurodesis at the bedside with talc or doxycycline, or it can be done surgically with a pleural stripping procedure or doing the chemical pleurodesis in the operating room. So those are all things that we would consider first for a persistent air leak or a bronchopleural fistula. From the perspective of a bronchopleural fistula, it just depends on the location and the etiology. Sometimes we'll do something really invasive like an LOSR flap or a Claggett window, where you cut out a rib and you stitch the skin down and you create a hole in the chest that you can then pack and control that way, and then try to let things heal from the inside out. Those patients may need to go on to receive a flap closure with plastics and us. So it just kind of depends. And patients that you don't want to take to the operating room, or depending on how, what their clinical state is, these are all fantastic options. I personally have seen the interventional pulmonary guys use pretty much all of them for patients with a persistent air leak or with a bronchopleural fistula. In fact, so Dr. Godfrey, our IP partner, did an Amplatzer device in a patient with a breakdown from a stump after a lobectomy. That was shortly after he came, which I think has been a year ago. Mm-hmm. So we definitely I have seen all of these things used at different times and depending on the patient and the clinical scenario.
Yeah, it's quite interesting, because we used to use Amplatzer devices for, whenever somebody needed, for example, a splenectomy or a nephrectomy, we used to, preemptively do a Amplatzer device for hemorrhage control. So they go to OIR or vascular surgery, we place this device in the artery feeding the organ of interest, and then occlude it completely. So when they go to the OR, they don't have massive hemorrhage. And those Amplatzer devices work quite well. So I just found it quite interesting that they're using these things, not just for endovascular, but rather endobronchial treatment.
Yeah, it's pretty cool. So the Amplatzer device, assuming everyone knows what they are, but if you don't, they're basically two donuts with a column in between. So it's almost like a dumbbell-shaped device. And historically, they've been used to close PFOs in the heart. So you can put them between the two atrium, and it'll seal off that space so that you get rid of the shunt there. And that's basically how we used it in the patient that I was describing, where you could see where the hole was in the bronchus, and so he tried to position it so that you had those two the two discs on either side to try to seal off the bronchus that way.
Yeah.
So,
The last device I saw was this Zephyr valve that we just recently had some of our pulmonologists train on it, which we're going to start using for COPD treatment. I was just wondering if you've seen it used for endobronchial treatment of bronchopleural fistulas or air leaks, persistent.
Yeah, so it's FDA approved for management of COPD, and it's considered an off-label use to use it for a persistent air leak or a bronchopleural fistula, and we've definitely used it in those patients, and they do a great job of describing it in the article, where you can interrogate the airways of the lung with a Fogarty catheter.
Yeah.
You occlude the airways and see if you can see the air leak stop. If you can, then that's your source of coming off of that airway, and then you can place a valve in. The valve is like a Heimlich valve, but positioned the other way. So the Heimlich valve, the flap is pointed down towards the ground, right? Because the air is coming out, and then you don't want to come back in through the chest tube. These valves are positioned the other way, so the flap is pointed into the main part of the airway, so that the idea is you don't want any air to be trapped inside the lung. That can come out and exit
And
the
not
new,
get back in.
any new air is not coming in through it.
Got it.
And yeah, we definitely use it for those. And that's Dr. Godfrey, my partner, was who did that first one here.
Ah, interesting. Yeah, because Fogarty balloons is something that we also have used in IR. Quite often for multiple things. I remember the most common most common reason we used to use it for was for hepatic vein, or whenever we did TIPS procedures to check for the hepatic vein pressures. So it was interesting that they use this balloon for many other reasons other than that. But I'm not as familiar with the Zephyr valve. I haven't seen one yet, so I found it interesting that there's also a off-label use for treatment of these conditions.
I can see. I'm looking right now.
I am sharing the screen if you wanted to show anything.
Yeah, I just did a quick Google search, but I can also, Dr. Godfrey just placed one on a patient that's on our service in Hartford and took some great pictures, so we could also pull up his op note and look at it. Okay, but yeah, here's so can you, okay, I think I'm able to share my screen.
Yeah, I'm sharing my screen, so you can go for it.
It says it's still
one second. Yeah. How about now?
Perfect. Okay. Here we go. All right, so right here, this picture, I don't know how well you can see it.
Very well.
It's not great, but you can tell though that flap that's normally pointed down towards the floor with there you go, perfect, it's focused, is coming into the airway. You're looking at, this is the bronchoscopic image of the stent placed in, or the valve placed in the airway. And here it's fish mouthing so that stuff can get in, and that's what you don't want. But yeah, that's basically the same picture that I was going to show you guys. I don't know if there's any other good ones. Yeah. But yeah, this is basically, and here's a bunch that are in position in the smaller areas, but that's what they look like.
Interesting.
The valves. They're pretty cool.
Now, is this something that you're looking at possibly doing in the future here at Bacchus?
I personally, so this is usually, so all the COPD ones are done under the purview of the pulmonologist and interventional pulmonary. So, if we start building up our experience here and getting, here's another one of it in place in the lungs. In the airway. If we get some good experience and good results here, then it's something that could be considered for a patient with a persistent air leak in the future. But it's usually one of the last things I consider, because it's really hard to kind of figure out. Like I said, like you're just sticking that Fogarty in each of the small airways, and sometimes you can't even find the one. And
Yeah, it seems like it would be very time consuming, and you would still have to have the patient under And not necessarily general anesthesia, or maybe you do have to have a general anesthesia, right?
General anesthesia, yep.
Yeah, because the airway would be compromised, I guess, at that point. But.
Mhm.
Alrighty, well, Dr. Worth, I don't have any more questions. I'm gonna leave it up to everyone who's on the Zoom call to see if they have any interest or any questions regarding today's topic. Any of you guys have any questions?
What's the longest bronchopleural fistula you've seen? I remember I worked with Dr. Flaherty back in the day in his office, and he had a guy on a dry atrium, I think for like 3.5 weeks.
Oh, that's much better. Sorry, I can't hear you at all.
I worked with Dr. Flaherty back in the day in his office, and he had bronchopleural fistula from a lobe resection. I think it was like 3.5 or 4 weeks on a dry atrium at home, and then one day it just sealed up, and that was it. I was wondering, is that like an average long-term fistula? Do they go months? Like,
Yeah, they definitely can. I definitely have patients that, so that's another thing I was going to say too, is that one option for that patient you described, although in the ER, is always to put in a chest tube and then send them home with a Heimlich valve or a mini atrium or, dry atrium, whatever your home choice drainage system du jour is. And depending on the patient and the situation, we'll very commonly do that. And I have patients that, it'll take about a month, but they do seal eventually. Yeah.
It's cool to have a conservative end game on a complicated problem like that.
Yeah, the problem is that now you're soiling the chest cavity because you've got because as you know, the respiratory system's not clean, and so now you've got potential contamination, and there's some argument that some of that contamination is good because that helps drive some inflammation and help seal it off, but you don't want to prevent empyema, which can also happen with the prolonged air leak, so it's kind of always this balancing act. Do we give empiric antibiotics? Do we not? How we manage that, but we sometimes do.
It's a good point. So old dogma I had heard from Rocco was you can have an air leak or an air space, but you can't have both because you end up with an empyema. Do you think that's valid?
That speaks to my point, is that, if you got that air space, then you're gonna naturally have effusion present to fill that, and then if you got that air leak, then it's gonna obviously get continued.
Elena, do you have any questions at all?
Not right now, mostly just taking it in because I haven't had much thoracic experience yet.
Okay. Desmond or Christina, do you guys have any questions?
Nothing for me. Very interesting lecture, though. Thank you.
Okay. Well, with that being said, Dr. Worth, I'd like to thank you again for your time. It's been a very interesting topic.